Dr. Cantor, you may begin.
Greetings to everyone, and thank you for attending the first session of the AAHCI webinar series on innovation in health professions education. I want to recognize my good friend and colleague, Professor Luciano Sasso, from the Faculty of Pharmacy and Medicine at Sapienza University in Rome, and Vice Rector for European University Networks, also at Sapienza, and President of the Unica Network of the universities from the capitals of Europe. I am grateful to Professor Sasso for spearheading the development of this webinar series, which includes sessions on simulation, digital solutions, ethical issues, and machine learning and artificial intelligence. I am particularly excited about today's webinar on the future of simulation, which will focus on the leading role of academic health centers in simulation and patient safety. Professor Sasso, the virtual floor is yours.
Thank you very much, Dr. Cantor. Hello to everyone. A very warm welcome from me as well. I'm Luciano Sasso, as Dr. Cantor said. It is a great pleasure for me to be here at this first webinar on the leading role of academic health centers in simulation and patient safety of the series Innovation in Health Professions Education. Health professions education is changing rapidly in many countries, and the recent digital push given by the COVID-19 tragedy is accelerating the process. Topics like simulation, machine learning, and artificial intelligence, digitalization, big data are becoming more and more important. Students of degree programs related to health should also be exposed more and more to ethics, intercultural training, communication, in order to perform well in the new global and digital society. That is why we are planning other webinars within this series on digital solutions in health on June 24, ethical issues on September 30th, machine learning and artificial intelligence on October 28th. And I hope that some of the participants online today will be also participating in these events. I would like to thank very much Dr. Stephen Cantor, President and CEO of the Association of Academic Health Centers International, Christine Keller-Smith, Director of Member Programs, and Abiba Belghedi, Program Manager. I would like also to thank very much all distinguished speakers for having accepted our invitation, and all participants for being online with us today. Without further ado, I would like to give the screen now to the first speakers, who is Dr. Paul Frampus, who is a professor in the Department of Emergency Medicine and Anesthesiology of the University of Pittsburgh. And he serves also as the medical director of the patient safety for the UPMC health system. He's the director of the Winter Institute for Simulation, Education and Research, WISER, and past president of the Society for Simulation in Healthcare. Dr. Frampus is an excellent speaker today because he has been involved in healthcare simulation for over 25 years. So you have the floor, Dr. Frampus, and thank you very much again for accepting the invitation.
Thank you, Professor. I appreciate the kind introduction, and I applaud the organization for arranging such an amazing topic series, and I think it'll be very useful for the future. And Dr. Cantor, I want to thank you for your invitation to speak at this webinar. So I want to I was asked to, I should say, talk about patient safety in simulation, and I want to talk about that from a role of working in patient safety, as well as having been involved in running a busy simulation program for many years. So I'll use the next 10 minutes to explore these concepts. to start with, I have no conflicts of interest or financial disclosures other than some personal consulting that's not necessarily specific to this topic, but general to simulation and patient safety at hand. So my role is one of a practicing emergency physician. As Professor mentioned in the introduction, I run the simulation program that I'll tell you more about here in a second. And I also have a dual role in the world of our health system as a medical director of patient safety for the health system. So I sort of sit and see two different sides of the fence, one in the patient safety world, one in the simulation world. And that evolutionary process that has landed me here has sort of given me, I think, some insight into both sides of the equation. WISER is a simulation program that serves the unique needs of the University of Pittsburgh. In particular, we work with the School of Medicine, the School of Nursing, School of Pharmacy, and it's the traditional university simulation center on that side of the equation. On the health system side, or the UPMC side, it's a very large hospital system with 40 hospitals, about 92,000 employees, 14,000 nurses, about 5,000 physicians directly employed. And the simulation program on that side is looking at hospital support, patient safety efforts, and working with staff and providers, professional education, residency education, and those kinds of things, as well as some unique things in terms of assessment of the hospitals that I'll talk to you about in just a minute. WISER is accredited by the Society for Simulation and Healthcare in all the domains of accreditation. We're also recognized as a endorsed center by the American Society of Anesthesiologists. So patient safety is a vexing problem. Those of you from the US and probably many of you from outside the US are aware of the patient safety problems that have been in the popular press in the United States, and they've been in the more academic literature for probably highlighted over the last 21, 22 years. And has been a growing concern for the population, for the government, for the healthcare system itself, and so on. And there's a lot of fanfare and sometimes hyperbole about patient safety and some critical regard as to some of the studies that calculate how many patients are injured. But suffice it to say, even if these numbers are off a little bit, it's too many patients that are injured while seeking healthcare, and we need to, and we're working hard to remedy that and make healthcare a safer place. Some of you may be familiar with the Swiss cheese theory of safety as it's applied to healthcare systems from Dr. James Reason, who's an industrial psychologist that understands high reliability organizations. And in this model, he postulates that there's this red arrow here that depicts harm coming towards the patient. And then there are layers of this Swiss cheese that have the holes aligned or not aligned based on the quality of each slice. And some examples are your staffing policies, equipment that's available, the training that's available, surveillance systems that go into it. And the goal is to make these holes in the Swiss cheese smaller, as well as move them around so that there's a deflection of this arrow. And of course, I think that it's easy to understand or get the idea that simulation could be one of those slices that causes the arrow to be deflected so the patient does not suffer the harm. So looking at how we can regard simulation or utilize simulation in that way is part of what I want to spend the next few minutes talking about. There's a number of different ways that can be used, that simulation can be used in this effort. Education is one. It's in education, using simulation for education is a very common, probably the most common implementation of simulation that people think about when they think about simulation in healthcare education. But I would argue that that's only a part of the pie of the potential for simulation in the future. I think assessment of both people as well as systems is a big part. Using simulation as a part of research to figure out which aspects of these interventions are effective or most effective, and then integrating them in the system and creating closed loop communications with the healthcare system so that we understand the problem. And in the case of simulation, we understand the role of simulation in the mitigation of those issues that are harming patients. So I mentioned about 20 years or 20 some years of knowledge of the issues surrounding patient safety. In 1999, our Institute of Medicine put out a paper called Two Eras Human and came forward with the idea, a conservative estimate that about 100,000 Americans die every year from medical mistake. In that particular body of work, simulation is mentioned 18 times as a possible solution. A lot of it is contextualized around teamwork and communications, not so much the assessment piece that I'm going to talk about, but as I said, it was mentioned 18 times, and this report was published in 1999. So I wrote an editorial recently talking about the implementation of simulation in healthcare patient safety. And one of the quotes in there that I wrote is, despite this, and I was referencing the Institute of Medicine report, there's not been widespread, systematic, consistent adoption of simulation into the patient safety efforts of of hospitals and health systems. So exploring a little bit about why that is the case is interesting. So part of it has to do with the foci of simulation. As I mentioned, most programs think of simulation as an educational tool, and it might focus on one or two healthcare providers. It might focus on teams or groups of healthcare providers, perhaps across different disciplines, those kinds of ideas. But very few programs have a deep embedded integration, looking at the hospital and then my depiction here of what runs the hospital, those critical systems inside the hospital, and how they link to the individual healthcare providers and others on the team that are caring for patients. And when you have a focus on the education piece, it's really hard to mature a relationship inside of this tightly integrated package where simulation and the hospital are working hand in hand at patient safety efforts. So that mission and the vision of your simulation program becomes critically important to direct where you're going to what you're going to pay attention to. So I always like to say that we need to monitor the pulse of the organization, find out what the needs are. Many simulation programs bring forward what they think is important without critically and at a base level understanding the safety and quality issues of the organization. In 2007, David Gaba published an article in Simulation in Healthcare talking about the future vision of simulation in healthcare. And he was talking a lot about patient safety and the integration of simulation into this deep level of integration that I'm talking about. And he said in that article, using simulation to improve safety will require full integration of its applications into the routine structures and practices of healthcare. So again, he's calling for that deep integration. He says the costs and benefits of simulation are difficult to determine, especially for the most challenging applications where long-term use may be required. So that article that I was talking about from 2 years ago that I wrote, I was talking about partnering and talking about the strategic relationships that need to go on between simulation programs and the health, safety, and quality risk management operations of the hospitals. And I think that partnering with quality and safety experts helps to catalyze a deeper involvement of where simulation fits and where it doesn't fit. I like to to show that this diagram showing simulation as embedded into the circuitry of the hospital. You have your nursing department here, you have finance here, you have risk management here, you have the laboratory, other clinical things here, and simulation is just another part of that bus, if you will, of the deep integration of the hospital. Because simulation is much less effective when you're just kind of bolted on at the back of the packing of the hospital and off you go, which is the case, sadly, for a lot of simulation programs at the moment. So I look at the simulation program as sort of depicting it out here, and then hospital infrastructure, no matter where your hospital is, whether it's a big hospital, small hospital, leading academic medical center, or community hospital, what I have depicted here exists in every hospital in terms of the different departments and so on. And I advocate for simulation programs to really create relationships with quality and safety of the organization so that they completely understand the needs of the institution that they are serving, and that they develop a 360-degree communication structure so that the simulation program efforts, as they get integrated, get reported back to the quality and patient safety to create this dialogue that allows simulation to become increasingly more important. I advocate for people to get access to data and generate data. I think that it's critically important that the simulation programs are aligned with the institutional goals, and I mean goals from a safety, quality, and patient experience perspective, not just the educational goals of the institution, because as you get to the health center side of things, that's where sort of the priorities shift away from education as being front and center for the efforts of that particular institution. And then what I have depicted here is another way of showing, okay, there's an issue on the safety front that might be appropriate for simulation. The simulation center creates a solution and then is reporting back to the system again to create that 360-degree set of communications to ensure relevance of the simulation in the hospital system. I alluded to a couple times already the using simulation as an assessment tool. Simulation as an assessment tool can provide significant insight to the hospital system so that the hospital system can understand at a deeper level its strengths and weaknesses. And that means looking at the systems and environments of care, as well as the possibility of assessment of individuals, assessment of teams of individuals. And many people think of simulation as that educational tool, but I don't think that we always need to use simulation. We should not be simulating because we can. We should be simulating when we need to use simulation as the tool. But simulation can unroof and measure those strengths and weaknesses of the institution and the hospital to allow the hospital to appropriately direct its funding insofar as risk and quality and the educational efforts, so that they get distributed to create the most efficient and effective solutions possible. So we can find these problems. We can help the hospital system release the funding that is depicted here into these channels to allow prioritization of different things. Now I have central line training, ICU ventilator management, crisis team training, postpartum hemorrhage control. I just picked some random examples of some programs that we've been working on over the years and try to create this idea that when we look at the risk quality data, we have identified some high risk areas, and then we use simulation as an assessment point to help drive the prioritization that opens up these valves to allow funding to flow to the simulation program to sustain it and further integrate it deep into the hospital circuitry that I had depicted before. So I want to wrap this up by saying I want to encourage simulation centers and simulation programs to become true partners in patient safety, not be that bolt-on suitcase that I showed you earlier, that you're deeply integrated and that you have a source of information for the opportunities and the needs of your institution. Think beyond simulation as an educational tool and recognize the assessment capabilities and the ability to use simulation creatively to solve actual patient safety problems, and figure out when is simulation right as an educational tool, when is it more beneficial as an assessment tool. And we published a patient safety report earlier this year that details about 30 of our different programs that we do for the UPMC health system. If anybody is interested in that report, we share it freely. I would like to put up my contact information here. There's a whole bunch of ways to contact me. If you do and you want our patient safety report, I would be happy to send it to you. So that concludes my time interval. I want to thank the organization again for the time to speak, and I look forward to the other presenters' presentations as well as the Q&A session. So thank you, Professor. I turn it back over to you.
Thank you very much, Dr. Frampus. Really very interesting, very inspiring for all of us. And we will debate your talk together with the others at the end. So I encourage all participants to ask the questions in the chat, and we will open the Q&A part of this webinar at the end. So now it is a great pleasure to give the floor to Dr. Ellie Karchenas. Is the Associate Vice President of Clinical Research Operations and Institutional Advancement at the Robert C. Byrd Health Sciences Campus of West Virginia University. The Associate Vice President for the Global Engagement Programs, Director of Technology Commercialization, and Associate Professor of Pharmaceutical Systems and Compliance at the School of Pharmacy at West Virginia University. So it is a great pleasure to leave the screen to you, Dr. Karchenas.
Thank you so much, Professor Sasso, and thank you so much to AHCI for inviting me to this wonderful panel. I'm truly honored to be here. I thoroughly enjoyed Dr. Frampus's presentation. I think he did just a phenomenal job to set the stage for this set of new technology that I really think they are breakthrough technology in future direction of not only medical education and training, but I think it will be impacting in a profound way a number of other industry sectors. So I'm going to share my screen. So I think what Dr. Rudy Frampus said, and he beautifully articulated on the importance of this set of technologies in the context of patient safety and how really this type of technology can improve quality of care. I'm going to also come back and provide a different set of angles that actually has caused the progression of this technology, which I collectively refer to it as an extended reality, because it can be a mix of virtual reality on top of augmented reality or mixed reality, and eventually, broaden to a whole set of new dynamics that can be used in these type of simulation training and experiencing. So if you really look at the traditional challenges of education, is that we've been really bound to a set of information that have been very tough to understand and comprehend in terms of the complexity of the content. Sometimes the lack of engagement, both inside and outside of classroom, have made the comprehension and absorption of complex medical and technical education very difficult. And of course, our traditional modality of teaching have been based upon fact retention rather than comprehension and reasoning. So these type of fundamental challenges that we have had in the last few centuries in delivering content to our students have really brought us to pretty much the brink of change. So in the past 15 years, there have been tremendous transformations in education and training, and certainly internet and social media have contributed profoundly to the advancement of these type of internet-based training. And of course, in the last 5 years in particular, virtual reality, by reducing the cost of the hardware, we have seen that they have become really common devices that are in a household, just like a tablet or a cell phone. These type of devices are becoming very common in not only gamification of certain type of entertainment, but also they have found their ways in learning and teaching to the extent that these type of technologies are now able to provide a simulation experience visually from an auditory, tactile, smell, taste inputs in a three-dimensional fashion. So the benefit of these type of technologies, as Dr. Frampis articulated, is obviously creating a better faculty-student engagement, better understanding of advanced concepts, aiming and learning by doing the procedure in a simulated environment, creating an environment where you can really gauge emotional reactions of the students to the content, obviously improving creativity and innovation without the fear of failing in a simulated environment. And of course, personalizing education and creating and learning and collaboration community. So if you really look at the industry sector for XR as a whole, you can see by 2025, it's actually over a $35 billion industry. Now, half of that really expenditure is still in the areas of video gaming, live events, and video entertainment. But you can see the other half is really finding its niche in healthcare, engineering, real estate, retail, military, and education. So it is becoming really a very large size industry as a whole. So far, there have been close to about 270 medical AR/VR companies that are specialized in 20 different clinical sectors, from phobias and PTSD to stress management, to surgical training and planning, physical rehab, pain management, exercise, cognitive rehab, opioid, optical rehabilitation, addiction, such as opiate or fear, neuropsychological assessment, cognitive training, sports medicine, disability solutions, speech therapy, autism spectrum disorder, mood disorders, patient education, preventative health, ADHD, and senior care. I mean, these are just a sample of the type of really simulation training that have been created across a wide variety of these type of companies that are being right now marketed and tested. So before the pandemic, the use of XR technology was really transforming the enterprise level businesses and had found its way into a day-to-day operations of businesses and healthcare organizations, universities such as ours, first responders, and other industry sectors. But a recent survey, actually, this is a 2020 survey of nearly 3,500 companies that were using the XR technology in 6 major industry segments, such as healthcare, education, public safety, manufacturing, workforce training, and retail. And you can imagine, as Dr. Frampis mentioned, that actually the pandemic put a rocket booster below this sort of a technology and send it to the sky, because a lot of organizations have started really adopting these technologies, whereas pre-pandemic, the adoption of these technologies would have been somewhat challenging. So at West Virginia University School of Medicine, we actually created a major initiative within Rockefeller Neuroscience Institute by really creating 2 principal objectives behind this initiative. One would be creating an environment where we could provide these type of advanced training for a large residency and fellowship programs across different departments of medicine that we had, and create an opportunity for our residents and fellows, medical students, nursing, pharmacy, and public health and dentistry students to go through these type of simulation environments with ease for their experiential learning and training. But the second objective was to really use this initiative as a launch pad to create a cross-campus interest with developing novel technologies that we could deploy across the whole university. Now, we have 5 campuses across the great state of West Virginia. It's a rural state. Obviously, we are the state leader in education, business development, and as an academic medical center, the largest healthcare delivery system in the state, encompassing 22 hospitals. So it's a large academic medical center with a lot of tentacles that are spread all over the state. So how could we really utilize this type of technology towards the advancement of rural medicine in particular? But at the same time, our vision was to really be a player in the extended reality technology that focuses in patient care, research, and education. So I mentioned that there are roughly about 270 of these companies out there that are providing various solutions in different industry sectors. We've been working with 50 to 60 of these companies, and so far we have identified 20 of these companies that we are in various stages of clinical trials, proof of concepts, creating simulation modeling. And the idea for us was not really to utilize just the technology, as Dr. Frampus was mentioning, using simulation because it's there, but rather creating neat cases that would match the technology, but with the idea that us, as WVU, would create the content, because we didn't want to rely on outside content. So that really added a new tier of complexity from a compliance, legal, risk management, patient safety, privacy and security, a whole set of new dynamics that we had to really factor into the implementation of these type of novel technologies into the fabric of teaching and learning. So we're working right now with BrickSimple and haptics through Zeiss for creating a simulation technology for craniotomy and brain surgery. This is a technology that is really adapted to Kenevo 900 microscopes that are used during the brain surgery or craniotomy. And it's clearly a novel technology on its own. I don't know of anyone that is doing it in the world, but clearly it is going to change the manner by which we will change the training of future surgeons in this area. Aardvark is a company that we are working with for creating an avatar for type 2 diabetes management, and really taking the whole notion of type 2 diabetes management from a 2-dimensional application that are, dozen a dime out there, to a new environment where patients are actually going to see themselves as an avatar that would really talk to them, engage with them just as a coach and as a provider, simply because behind the engine, as Paul mentioned, it is really attached to artificial intelligence, to real world data, patients' data behind the engine that can be engaging with the patients on a real-time basis, on a daily basis. Actually, we just finished the proof of concept by shooting the videos for 4 surgical procedures in ENT, the ear, nose, and throat. This is a surgical simulation technology in ENT that we have really created for our fellows and residents that we are going to be using in their training. Floria is actually a treatment application for autism spectrum disorder. It is now being tested by clinicians and providers in behavioral medicine. Soundscape is actually used at the hospital right now with patients with cancer through music therapy. Caption Health is used at our simulation center with students that are going through their third year and fourth year students that are going through their training. And this particular technology is providing them ultrasonography for cardiac arrhythmias through this type of novel applications that they have. And we have brought it here to train our med students. Mirion VR is a company that is specialized in homeopathic medicine. So a lot of their application is going right now and tested in pain management, chronic pain management, like patients with low back pain, patients who are on chemotherapy. They are being tested in this type of environment for their applications and against the standards of care. LBX Immersive is a company that we've been working in the last few months to actually take the hardware out of the context, because obviously a lot of institutions are worrying about investment in hardware and knowing that 6 months from now or a year from now, most of those hardwares are going to be outdated because of the advancement of technology. So LBX Immersive came to us and really took the issue of hardware diversity, whether you're working with HoloLens from Microsoft, or you're working with Google Glasses or Oculus or various haptics. They took that off the table. So we actually now are able to bring in this set of headsets or haptics into the classroom settings, and the students can check them out, just like a textbook they do from the library or from the bookstore. They can actually swipe their card and check it out, and at the end of the semester return that. And there is a device relationship management that keeps these hardwares constantly updated with the latest software. Education XR is a classroom-based setting which creates an environment for students to actively engage with a professor, with the instructor, in a very real-time scenario. So that is being tested, and we are creating content to bring through a company which we call it Induvo. That's number 15. That we are, as I said, we create our own content from a two-dimensional and transfer it into a three-dimensional simulated environment. MindMaze is a company that is right now located here on campus. It is out of Sweden, working with us on various gait and movement disorders, patients with Parkinson's or patients with tremor. SciGlass is a startup company that was really sprouted from our own innovation incubator. It is involved in bringing real-world data into an augmented simulated reality, which would allow us to engage at this cellular level for protein target development. So it's really an amazing technology that has created that allowed us to actually, during the COVID time, to work on a number of potential vaccine sites for the virus itself. Microsoft HoloLens, we have an active contract going on with Microsoft on their HoloLens technology, that they are really going in all directions, from engineering to mining to medicine. Augmetics is a company that is specializing in orthopedics and spine surgery, that is currently working with us in developing novel simulation technologies in that space. Medivus is something like surgical theater for craniotomy. It actually can bring in an augmented reality. So if you have a PET MRI, it can actually project it onto the surgical site at the time of surgery, so the surgeon can actually see exactly the margins of a tumor that they are resecting with high precision. OVR is the olfactory virtual reality. It's a company that we just started actually working with them. They have a novel technology that has 9 actuators just sitting below the headset, and these 9 actuators can, each one of them, emit a different smell. So we can take the patient through aroma therapy by simulating 9 different environments for patients who are suffering from chronic pain, or patients who have lost their sense of smell. You can actually start, particularly during this COVID time, we can use this type of technology in either reducing pain or bringing their olfactory stimulation back. And BrainKey is a company that we are working with right now to quantitatively determine the size of the brain before and after surgery in technologies that can really show if these patients are developing neuroplasticity, increasing their brain volume, particularly in patients with Alzheimer's, through a technology that we are using for focused ultrasonography. So these are just a few examples or case examples of the type of things that we are doing through XR initiative. In addition to that, we have really created a certificate program level that at the beginning, it is going to be presented as an XR course this fall, but later on is going to go into a postgraduate certificate, which we will be offering to professionals that are interested to learn more about this technology and the use cases of it. Obviously, as Dr. Frampus mentioned, none of these technologies would happen without proper funding and connecting it to your financial modeling. So these type of initiative had been really supported through a large variety of investigators and providers and clinicians, at least at the 5 schools that are actively testing this: School of Medicine, Pharmacy, Dentistry, Nursing, and Public Health, through submission of NIH and NSF grants, through the WVU Foundation, state-level support, and of course, non-government agency. I'm going to stop here. This is my information. As Dr. Frampus showed his information, this is my information. I will be more than happy to assist in any way if the audience has questions, but look forward to the questions and answers section. Thank you so much.
Thank you very much, Dr. Karshenas. A really excellent presentation. So we will open the discussion at the end. And now it is a great pleasure to give the floor to Professor Suresh Pillai. He is a specialist senior consultant at the emergency and also emergency physician in the National University Hospital, and is also the director of the Center for Healthcare Simulation at the Yong Lu Lin School of Medicine. He has been instrumental in reviewing medical simulation training at his school by developing new simulation programs that integrate into existing curricula. Over the past few years, he has developed and introduced simulation training as an integral part of medical undergraduate training at his school. He also has developed international award-winning virtual reality simulation training modules for medical undergraduates and runs the virtual reality simulation laboratory at the Center for Healthcare Simulation at the US, the National University of Singapore. He's also actively involved in undergraduate medical education at several other levels and formulated the first undergraduate emergency medicine program. So it is a great pleasure to leave the floor to you, Professor Pillai.
Thank you so much, Professor Sasso. And let me share the screen first. And thank you very much also, Professor Karshenas. I think it is amazing to see how academia has actually merged very nicely with industry partners to develop virtual reality simulation. So thank you for the organizers to allow me to share what we have done with virtual reality technology. I've been specifically asked to share what we have done in our own little way to develop virtual reality simulation in our university, right? So some background. We looked at how we can integrate virtual reality simulation into our undergraduate curriculum, and we looked at human anatomy, all right? From feedback, from talking to faculty and students, we realized that there is a disconnect in the conceptual understanding and clinical application of human anatomy. So we thought, can we actually marry a hard science like human anatomy, which is, steeped in age-old tradition and conformity, and merge it with something like virtual reality? Is it possible? Indeed, there's already 2D visualization that is used extensively in the learning of human anatomy in the undergraduate level. You have your anatomy textbooks. You have 3D applications in 2D. This is the Anatomach table, which incorporates 3D applications in a 2D format. And then, of course, you have 3D apps, in computers and so on and so forth. We looked at 3D visualization techniques that are available right now. Of course, the cadaveric dissection is still there. However, in many medical schools, just like in our medical school, the exposure to cadaveric dissection is actually limited because of the dwindling number of cadavers. And in many medical schools, I think the US, only about 63% of them still have some form of cadaveric dissection in the undergraduate medical curriculum. So in the NUS, the faculty, the anatomists has resorted primarily to anatomy prosected specimens that they actually dissect for the students and demonstrate for the students, of the various structures. So we thought, what about, getting them to understand the 3D spatial visualization of the human anatomy, right? Despite other 3D visualization technologies like, simple plastic models, we thought, why not go one step further? So we looked at how anatomy is being taught, and we thought that, 3D spatial relationship of complex structures was something that we want to look at. And we looked at 3D visualization technology, and we decided to embark on this journey of looking at an alternative 3D visualization technology, and that's how virtual reality simulation came into the whole picture. So I think I'm going to show you, I've been asked to show what exactly we did. So I'm going to show you some videos, maybe that will make it a little bit clearer. But when we had the grant a few years ago, our mandate was to develop immersive virtual reality medical simulation systems for medical students using state-of-the-art software and hardware to create a kinesthetic learning environment. And with that, we developed two systems, Virtual Interactive Human Anatomy, or VIHA, and the Virtual Interactive Simulation Environment, VISE. This was maybe a few years ago. The projects were just completed a couple of years ago. And I just want to also emphasize to the audience that at the end of the day, technology is going to be a complementary methodology. It's not going to replace anything. And this is one of the things that we found, because one of the challenges we faced was anatomists, our faculty, feared that technology is going to take over their roles and their jobs. And we wanted to reassure them that actually, at the end of the day, it's a complementary methodology and technology. It doesn't replace the traditional teaching that still occurs in medical schools. So I'm going to just show you a clip and see if it works. This chronicles our journey, and we developed this in-house in the university itself. All our first-year medical students are using it right now.
In VIHA, you can pick any body part and visualize it from any angle, as if you were to take a closer look at any real object. You can also pick up bigger body parts like muscles and bones at ease. To study smaller body parts like arteries, veins, or nerves, you can filter off the rest and focus only on specific functional systems. You can walk around the VIHA system to view it from any angle to understand spatial relationships.
We can't do this with a real cadaver. We can't go around a cadaver.
Every body part snaps in place whenever it's near its original position. Whenever you touch a body part, the respective annotation is shown. so you're always well informed of what you're interacting with at all times. To view regions like the lower limbs, you can squat or you can move the cadaver up and rotate it to the best viewing angle.
So interactivity was the key. So with that, how do we actually use this system? That was the virtual cadaver. So with that, we discussed with the anatomist to actually develop lesson plans. I'm just going to show you just some clips of specific lesson plans. And this was actually based on their curriculum. So in the first year, there are 6 sort of regional areas. We focused on that. And each of it has a specific aim. This is the upper limb. And the focus is all on functional anatomy, what they found difficult to visualize. And we were very clear not to replicate the textbook. Lower limb, we focus on the gait, cycle. What muscles are involved, what nerves are involved in allowing someone to walk. And we looked at the difficult to visualize areas like the thorax. We focused specifically in the middle of the chest, the mediastinum, looking at 3 complex structures, the heart, the lungs, and the mediastinal structures. And we also looked at the abdomen. In the abdomen, we focus on a weakness that the students had, which is the embryonic development, okay, which can be quite difficult to comprehend even for a surgeon. And also we looked at the pelvis and the perineum, small little structures with complex organs. What is the relationship of the various organs in this small area in the human pelvis and the perineum? And finally, the head and neck, another complicated area. So this was just a snapshot of what we have done with virtual reality simulation in our undergraduate medical curriculum. And part of this project was also to develop a interactive simulated environment. And our first project was to create mass casualty triage scenario. Now, fortunately in Singapore, we don't have natural disasters to the extent that many other countries have. But that lies a problem because we do have industrial accidents and mass casualty incidents to a certain level. And one of the principles that we wanted to teach our learners was a principle of triage. All right, so I'm just going to show you what we did with the virtual interactive simulated environment. Show you a clip.
I repeat, to anyone who can hear me, move towards my voice and we will help you.
Mass casualty multiplayer environment, 20 casualties, 4 to 6 learners, and they have to triage.
Wave your hands and we will assist you as soon as we can. Hi, I'm here to help you. How are you feeling?
One of the things we wanted our developers to do is to ensure that the actions are really lifelike, realistic interactions, and following a triage protocol known as SALT. So literally you have to go down onto your knees and hands and knees, opening the airway, look, listen and feel for breathing. There are time limits.
I need you to relax your finger.
Checking for capillary refill. And finally putting on a triage tag and deciding what is the priority status. See, the learners are literally interacting with a virtual patient in a mass casualty environment. So there are some casualties who are not survivable, so we also want to know what they do with casualties who probably are not going to survive, so they have to tag, okay? The casualty according to the severity of the injury as per mass casualty triage protocols. And they have an instantaneous, response as to whether the actions were correct or not. All right, so I'm trying to keep to the time. That was just two of the projects that we were fortunate enough to have funding to develop. And one of the things that we used to get the funding was to actually pitch virtual reality simulation as a future medium of educational instruction. And this was before the pandemic. And of course, with the pandemic, right now, there has been a huge explosion, a rocket booster, as was mentioned by Dr. Krampus. And there has been a big paradigm shift, I think, accelerated by the COVID pandemic, from passive learning to more experiential type of learning, right? And what we wanted to emphasize in our system was make it as realistic as possible with hand gestures, voice directives, vision gaze controls, and even a sense of smell, which as was mentioned by Prof. Kashinas earlier on. And ultimate learning mode is to be fully immersed in the task and actually doing it, right? And at the end of the day, we were also very conscious of the fact that, are we just using technology just because it's sexy, just because it's the latest fad? And is it always the best answer to our problems? I think, as I mentioned at the beginning of this talk, that technology for us, we were very, very conscious to ensure that it is a complementary methodology and technology, especially in medicine. And we should not forget time-tested methods like role modeling, experiential learning, and good old-fashioned storytelling as part of medical undergraduate education, all right? So we are fortunate enough to have this project, receive an award a few years ago, the Reimagine Education Awards. And with that, we hope to develop more virtual realities simulation system at our university, all right? So with a short sort of presentation, thank you for your time, and thank the organizers for allowing me to share what we have done in our own little way. Thank you so much.
Thank you very much, Professor Pillai. Really very interesting presentation. Thank you very much. And now it is a pleasure to leave the floor to Dr. Matthew Czarneski. He is currently the Director of Simulation-Based Education and Research at Dartmouth Hitchcock Medical Center, and also PhD students in Europe at Maastricht University. I'm very pleased to hear that. Matthew has had a very interesting life. He has been fortunate enough to have a career spanning the globe from Iowa to Antarctica, Tanzania, Kazakhstan, and back again. So working in support of science and medicine, in information technologies, wilderness, and pre-hospital medicine, and finally in healthcare simulation. So looking forward to listening to you, Matthew.
Thank you so much, Professor. Thank you to the other speakers as well. I'm really impressed with what you guys are up to, and certainly have a lot of things to descend my team upon. I wanted to talk a little bit today about cultural considerations in simulation curriculum design and curriculum transfer. And this is kind of a new concept that we're talking about a lot more. I don't have anything specific to disclose, at least not related to this, but I did want to talk about, I've been involved in a number of trans-border educational partnerships. Between that and just seeing the increased education globalization, adding more students coming from other places, but also education being expanded out to different locations around the world, but also interregionally. And then increased, I think, around the world, but particularly in the United States right now, are conversations about diversity issues, both in education and surrounding healthcare. And adding to that, this intersectional nature of culture, that each of us are made up of all the different experiences that we have. All this can lead to really increased diversity in our learners' future patient populations, in the healthcare teams that they'll work with, our learner populations themselves, the faculty that we're working with, and even in the care context that we're trying to prepare all of our professionals for. Because of that, that leads to some things that we need to think about more when we talk about simulation and when we design our simulation. One of those things is cultural fidelity, adding those elements to our simulations and making sure that they are as realistic as possible, that they represent the potential future context that our learners will be in, and challenge them to grow in ways that they might not traditionally have or might not traditionally have been exposed to. It also gives us an opportunity to increase inclusivity in our educational environment, and that translates into the healthcare professionals environment as well. And we've seen that this inclusivity and this attention to cultural fidelity can then increase equity, both on the educational side and in the healthcare delivery side. And then it allows us also to accommodate more different kinds of things. Many of us work in perhaps some more homogenous parts of the world, but we're still trying to train our learners to better prepare for different places where they may work and those different populations that they could work with, both interprofessionally and with their patient populations. And so with this, we have an opportunity in simulation to create all of those experiences and things that lend to building the skill set that we need for that. In the recent work that I've been doing with a couple of different research teams, we've been doing some systematic and scoping reviews, really just to look at what the current state of research and conversations surrounding cultural considerations is. What we found specifically in interprofessional healthcare education and also in simulation debriefing is that not a lot of people are talking about it. The primary focus tends to be on that provider-patient interaction, but we're not paying attention to more of the underlying things related to curriculum development, to learner-centered design, learner experience, faculty experience, and that sort of thing. In the papers that we've found so far, most of the methodologies that they've gone through for incorporating or accommodating cultural considerations are really poorly described. They often don't describe what cultural model they're working from, which, as you might imagine, there are numerous, nearly unlimited versions of this. And they also don't talk specifically about how they include it or how they examined it before they included it. We also found that the complexity of cultural elements. So when we often think of culture, typically we're thinking of global or national culture, which is the focus of a lot of my work. But in reality, culture is really this culmination in an individual of every different part of their belief system, their experiences, and their identity that come together to create this unique individual. So because of the complexity of this, and because a lot of the research that's been done hasn't focused on, or excuse me, been really specific about those things, what we found was it was difficult to compare things, and it was often unclear exactly what they meant when they were talking about cultural considerations throughout their research and their learner experiences. And then the other thing that came up that was particularly interesting to me was that typically in the conversations about this, when we look at the cultural differences that we're trying to accommodate, the distinction was that the patient was the other, and that the healthcare professional, the learner, the faculty, all of those people were actually the base. They were the people that they were sort of the majority, and the patient was who had to be accommodated. And our position was that truly this is something that needs to be seen all the way around. And we see it in some different trainings in different health professions education. But again, we're not being particularly specific about it. So the last bit from our recent work is that the vast majority of things that we were reading had a distinctly Western perspective to them. Simulation is a little bit more common, a little bit more ubiquitous in Western education, but we're seeing it spread more and more throughout the world. We're also seeing it find its way to different cultural regions within those areas. And with that, when we apply the Western perspective, we found some really severe limitations of things that we were teaching or things that were being spread as sort of incontrovertible truths. Specifically with debriefing, we found that a lot of the things that we rely on really specifically as underpinnings and conceptual frameworks for our debriefing methodologies may or may not work in different cultural contexts, both depending on the relationship between faculty and learner, but also the educational and experiential background of those learners. This raised some pretty significant red flags and led us to really understand that we need to be expanding what we're looking at, how we're accommodating those things, and getting back to that learner-centered methodology that we talk about so often in curriculum. In my current studies, I have 2 studies currently running concurrently. The first one is a scoping review specifically looking at global, national, or ethnic culture and how it's factored into simulation curriculum design, and specifically in the transfer of curriculum from one location to another. So when we look at these curriculum partnerships that cross borders, cultural boundaries, what we find is that there are some really small differences that sometimes produce really significant results. Something as simple for simulation, something as simple as a job that you have your patient who that's where they work, that's what they do. If that's significant to the case somehow, if that job doesn't exist where you're transferring your curriculum, or if it doesn't have the same implications, that can make a huge difference in the curriculum itself. But the other thing is when we talk about certain treatments or certain experiences that our learners may have with patients, we find that those are so distinctly different between different cultures that we have to be preparing our learners to be a lot more agile related to that. And if we're not factoring that in and considering our learner population, our educational context, and the future healthcare context, we're missing an opportunity to really make those high fidelity experiences hit home and really, truly valuable. In my scoping review, we started with about 5,000 papers from PubMed, Embase, ERIC, and Web of Science, just trying to get a really broad collection of everything that might be out there. And we had to start incredibly broadly because this wasn't something that we have the language to even speak about specifically. We're working on it, but right now, cultural considerations in particular, or cultural competency or cultural humility, lands on mostly those educational situations where we're trying to teach the learners about interacting with patients of different cultural backgrounds. Occasionally, we would find things that were going the other direction, teaching learners how to deal with the bias or the cultural backgrounds being impressed upon them by their patients. But again, we weren't really looking at the actual curriculum design or the process of developing and transferring those curricula between locations. So far, our initial results are really showing similar things. We're not seeing a lot of specificity in the conversation. People aren't talking about it, even if maybe they are doing it. So from a scoping perspective, this is really interesting that it's something that we haven't maybe spelled out. Perhaps people are doing it, perhaps they aren't, but there's a real opportunity for us to do that. So in my second study, what I'm looking at is first the perspective of the home context. So people who are designing these simulations or creating these simulation-based experiences for a home institution that are then being transferred elsewhere later. And talking to these people, doing semi-structured interviews with them for both international and interregional sites to determine what sorts of things that they considered in their needs assessment when working with these other sites in terms of what sorts of experiences to translate, things that they had to change about it, and what specifically those things were, and then also the methods that they used to try and find the answers to things. And from this, what we're already starting to find, things that are coming out, are much of the time those initial needs assessment conversations happening in international partnerships aren't sufficient. People know what they want, people know what they see, but sometimes we're missing the real root of that issue. And having the opportunity to get a little bit deeper and to add more experiences to that, often outside of the educational context and outside of the perspectives of specific faculty, truly looking at the healthcare context, getting to know the culture, and having conversations surrounding all that have proven to be really important in determining what cultural elements may be different and what we need to be ultimately changing in those curricula as we transfer them. I do want to take a moment to thank all the members of the research teams that I work with. I'm very fortunate to work with some incredible people who have really pushed this forward. And with these folks, what we're really learning is that we have this incredible opportunity to make our education much more learner-centric. We have an opportunity to increase both the cultural fidelity, but the overall fidelity of all of our simulations, which can help with engagement, can increase the transferability of those experiences. We also have an opportunity to create better representation and inclusion of different cultural elements. And in doing that, we increase the potential psychological safety for our learners. We increase their retention, both of knowledge and retention of these people into our programs. And we can increase their engagement with the curricula, both in simulation, but everything surrounding it as well. And then from this, even indirectly, the hope is that we can increase cultural humility, cultural awareness, and cultural skill, which are all things that we're finding are really important for healthcare professionals as we send them out into the world, but they're also really important for our faculty and for our educational systems to be engaged in with those learners specifically. So that's everything in brief. I can certainly go into it for hours on end. Here's my contact information, and I'm happy to speak about any of these things, either whether it's about what you're doing or things that we're doing and how we can integrate those things.
So thank you very much, Matthew. Very, very interesting. Also for opening, our eyes to actually other realities and the more worldwide picture of the situation. So now I would like to ask all the panelists to come back to the screen. We open now the floor for discussion. Yes, there is already, I see a question in the chat from Michele Mariscalco, is from the University of Illinois, Chicago. And in institutions where simulation team is not part of healthcare delivery enterprise, what have you done to improve that bi-directional work? So I guess this is a question for all panelists. I ask maybe Matthew to, I don't know if you are sharing the screen, or I would like to have all the panelists now on the screen. Yeah, okay.
Yes,
Perfect.
everyone is on.
Perfect, great. Okay, so I see, I see everyone now. Okay, thank you very much. So who would like to start with this question?
I can start. I think that is a very good question, actually, and I think that is sort of a functional and a structural question that at the early onset of this type of initiative has to be vetted very carefully, because the likelihood of an institution to go rogue in this type of simulation technology through one particular department, let's say engineering or creative arts or computer sciences, and not being able to disseminate that information or creating to form alliances and collaboration with other institutions within the same university or institution would be very, very likely. And we have seen that quite a bit. And some of the learnings before we really deployed our initiative here at WVU, we were very, very careful not to create pocketed initiative in one particular department, because it would have translated into duplicate investments, duplicating your resources and efforts. And at the end, the institution as a whole is not getting a whole lot of return on investment. So at the beginning, there is got to be some buy-off at the institutional leadership level, where they agree that this type of technology would have a much, much broader implications across the institution as a whole, and be able to get an agreement at the leadership level to bring the key stakeholders around the same table to talk about which specific applications would be targeted for development at the beginning, and what would be the impact of these type of applications on broader institution. I think that's very, very critical at the beginning to have that buy-off from the leadership at the institution.
Thank you, Ali. Other comments on this point?
I'd like to add to that. I think our experience here has been, we often find that simulation is so often, as Paul was saying earlier, so often only thought of as education. That we miss the opportunity to look at all of the other places that it fits, particularly in a healthcare system. So my original background in sim was almost exclusively academic centers, not academic medical centers, but truly academic institutions. And moving into an academic health center, what I've found is that often there's a phrase that has come up in my life. Often the buyer has no imagination, and there's a leap that has to happen for people in risk management, in quality, in patient safety, to understand all the possible ways that sim might play a role in this. And just like Paul and Ali are both saying, bringing that to them and helping close that gap, even just a little bit, really opens their mind and opens the opportunity. Here, what we found is our biggest challenge was just getting a seat at those tables and having the opportunity to start that conversation. And once it started, lots of things opened up and people have some really fabulous ideas I never would have imagined. But it was just getting to the table and opening that conversation.
Thank
Yeah,
you.
I think I think that tying on to what Ali started and Matt ran with, I think is important. The governance structure and the mission and vision of the simulation program, if it does not involve patient safety, then that's a sort of a non-starter to become embedded into your institution. And if it does have the patient safety in core embedded into your mission, then you have to be able to be in the loop and get those seats at the proverbial table that Matt was just talking about. Because the challenge with simulation is, if you lead with education and say, I'm going to make clinicians better and smarter, the financial and C-suite people say, I already pay for smarter, better clinicians. What do you mean? So you have to be more than a fancy education tool. And I'm not slighting simulation. We get the power, we get what happens, but I think that we have to shift our vantage point to solve the solutions of other people in the C-suite. So your risk management teams, your safety teams, your quality improvement teams, how do we position simulation as a tool to solve problems that we don't know exist? Of course, we can simulate central lines and airways and anatomical structures and all that kind of stuff. And if we lead with that, it may or may not be addressing the problems at the other end of the table that directly affect quality and safety at the patient bedside. So we have to make sure that we're opening up to that, becoming part of that dialogue, and creating solutions that involve simulation. And then the other thing that I found early on with my seat at the big table, if you will, is kind of saying, whoa, that's not really mature in simulation yet. We could pour a lot of resource into that, but I don't think we're going to get the intended outcome. So being a steward of the investment in simulation, I think, is very important.
Thank you.
I just want to add on to that. One way is to actually think of simulation in a different way. Definitely patient safety, reducing errors, it's going to attract attention. But I think one of the ways in which simulation can help is in systems design, even test designs. How many hospitals, how many ICUs have been built only to find that, they can't get around a corner or they can't bring equipment in. So that's one of the things we are trying to convince our leadership to. A certain extent, it has helped, but it's a challenge. So I think sometimes is to offer them, what we can do, offer our center, offer our expertise in testing out systems before they start building expensive areas and expensive, centers. So think of, different angle to it and offer ourselves, because very often people may not know exactly what the simulation center does. Leadership may not know. Yeah, so you need to get the buy-in and telling them what exactly we do and can do.
Thank you. I encourage again the participants to put their questions in the chat. We still have a few more minutes for discussion. And in the meantime, I have a very general question for the panel. In Europe, in the last year, I mean, in this difficult period of pandemic, we discussed a lot about the digital divide, the technological divide. We noticed that, you know, different institutions, different regions of Europe reacted differently to the pandemic just because they had a different means, technological means, etc. And we saw, and thank you again for your beautiful presentations, how fast is this field proceeding. I mean, the technologies are improving in an amazing way, but also the cost, as Professor Kashenas mentioned, this is also sometimes very expensive. So how do you feel if we look at health, I mean, as a global issue? Is this something dangerous? I mean, are we going to leave behind some schools of medicine in some countries which will not be able to equip themselves with these new technologies, etc.? Or in some other countries, maybe this can be also an opportunity to really start, let's say, the teaching of anatomy. As Professor Pillai mentioned, it was amazing. I mean, how to study anatomy nowadays in that way is actually more fun. That's, I think, 20 or 30 years ago was quite boring, if we may say. And then this can be also an opportunity maybe to start, education that way. So how do you see these challenges, I mean, in terms of opportunities and challenges?
I think, I'll start, and certainly my friends and colleagues can add on. If for the audience, they're not aware, by February 2024, all of the foreign medical schools, if they are not accredited through the WFME, the World Federation for Medical Education, they will not be able to send their graduates for postgraduate residency to the United States for training. I mean, that's really a fact that is known. And a lot of medical schools around the world are trying to hustle to get to that date by February 2024. And of course, the WFME accreditation is really the ACGME accreditation equivalent. So from that perspective, obviously, here in the United States, if we are going to be admitting into our residency matching systems foreign medical graduates, they have to abide by certain standards that is accepted here. So as a result of that, this pandemic surely created major obstacles for those graduates that wanted to come to the United States for advancing their career, but they couldn't because of the travel restrictions. So I really see this type of technologies to come in and not only fill some of the gaps that we may experience in education and experiential learning, but also I think it will prepare the future generation of healthcare professionals in a way that is going to be unprecedented. Clearly, around the world, I think these technologies are very easy to adapt to. The cost, as I said earlier, is coming down very rapidly. And the technology is becoming so operationalized to the extent that you don't have to be married to one set of hardware, because it is becoming very democratized across all of the content. So as a result of that, it makes the adoption much, much simpler. But if we were to think that this is going to be a pandemic of last time, obviously we are living in a panacea, and we shouldn't, because there may very well be another pandemic lurking behind it. So I think this type of technology is really preparing us for next set of major lags that may happen in our education, operational, supply chain, I mean, you name it, that will prepare us. And I think it has its own place, as Paul was mentioning in his opening remarks, that we have to be just careful that not to be deceived by the fanciness of this technology and think that it can be a solution to all problems, but rather selectively pick the right strategy that fits the need and eventually uses this technology as a solution.
Thank you. Other comments on?
I think I would second one of the things that that Suresh mentioned in his presentation. Number one, we can't ignore the tried and true methodologies. As these things come out, there's certainly an early adopter end where things are much more expensive. And then as we see them rolling out, we often see more competition and prices change and that sort of thing. Personally, I'm so excited about mixed reality and the role that that is increasingly playing. When I've done any work internationally, or certainly with any underserved or less funded organizations, I think that's been a place where there's a real opportunity for the costs to change. As Ali was mentioning, the hardware is becoming a lot more ubiquitous. It's becoming less that this software can only work on this hardware. And as we see that, the costs change and the opportunity really becomes much more democratized. And then I think this also is a little bit where we're seeing a changing role in academic health centers. Right now, we're seeing it with nursing very heavily in the United States, where we're seeing these recent nurse graduates whose clinical experiences were significantly disrupted by COVID. And we're having to come up with ways to offset that as we bring them in, as we hire them, and as we train them. And I think increasing that partnership in the United States, again, USMLE Step 2 is gone now. And so seeing how that changes exactly what we can expect on the receiving end really is going to require some examination of simulation, but education from an efficiency and efficacy standpoint.
Thank you. Other comments maybe on this?
I think another thing is with the technological sort of floor lowering in terms of barriers to adoption, people in underserved areas of the world and in developing areas have more ready access to people in the developing world than ever before. And I think that this every year, this is becoming more and more possible. When you just look at the you know, what we're doing here with Suresh seamlessly coming in from Singapore, Professor Yu from Rome. And I think that allows a healthy cross-pollination of ideas that I think will only catalyze the future of particularly developing areas and underserved areas to be able to rise up quicker than previous in all aspects of the education, because the technology is becoming affordable and available.
Thank you. Dr. Pillai, maybe?
Yeah. So I just wanted to add just another angle. You know, when COVID is done with, God knows when, but I think one of the issues is, are we going to carry on with this technology? And one of the things I think we need to remind industry partners is the sustainability in making sure that this continues. I think one of the things I found is that Ali has probably more experience with industry partners, is that they have no idea what medical education or what exactly we want. Is very new to them. They are more into gaming, and the industry is developed through gaming. But I think it is also, we have a responsibility here to make sure that we harness you know, the true utility of simulation of, you know, all this technology, and make sure that it continues, because I would, you know, it'd be a shame that when everything is done with, when we go back to normalcy, whenever that is, that all this will just die a natural death, and we would have missed a golden opportunity to actually move forward.
Yeah.
Perfect. So thank you very much. Unfortunately, the time is over now. We need to close the webinar, but I would like to thank very much the excellent speakers of this webinar. I would like to thank the participants for being online today, and also again the AAHCI for organizing this excellent event, and in particular Abiba Belghedi and Chris Smith. And I hope to see you next time. As we said, this is a series of webinars, I think really there is a lot to discuss, and the world is changing so much, and I think it will be really interesting to debate under the umbrella of this organization. So thank you very much and see you soon.
Thank you so
Goodbye.
much.
Thank you.